Now we're going to hit the largest family of DNA viruses, which are the herpes viruses. There's a lot of clinically relevant things that we have to talk about for the herpes viruses. You already know that these are icosahedral viruses that are enveloped, all right? So with herpes viruses, we're really talking about sexual contact or direct contact, but these are not things that you could generally pick up from an inanimate object or a fomite because of the envelope. What's going to help you in diagnosis is going to be that the virus will form intranuclear inclusions, because what did I tell you? I told you that assembly happens in the nucleus. So you can actually find that and use it for diagnosis in a lot of the herpes viruses. And again, this is the main virus family that establishes latency. So there are a few extra things that we have to know about herpes viruses. Number one, we have to know what the primary infection looks like. And I gave you the example earlier of VZV. We then have to know where it goes latent. So in a case of VZV, primary infection, chickenpox, latency in the dorsal root ganglia, reactivated infection, shingles. Okay? So those are some of the things we're going to look at as we're going through and talking about the different herpes viral families or specific viruses. All of these viruses that you see listed here are the herpes viruses. These are all considered high yield for step 1 of the USMLE, so we want to make sure that we know all the details of the herpes virus family. All right? Now, we're going to start with HSV1 and HSV2. Of course, HSV stands for herpes simplex virus, and we have the two basic types. We have HSV1 and HSV2. They are typically mucosal pathogens, but again, in general, HSV1 infections, we say, are above the waist, and HSV2 infections are below the waist. Transmission is by close personal contact. Again, these are enveloped viruses. The pathogenesis for HSV is that the virus is going to establish infection in the mucosa, and what is hallmark for HSV are going to be the formation of vesicles. Now, I'm warning you, they make it sound in a lot of board review books like this is like the thing to get, right? How do they describe the vesicles? They describe them as a dewdrop on a rose. That's almost romantic. You might actually want one of those if you didn't know better. And the dewdrop on a rose speaks to the vesicles that you see with HSV1 and HSV2. The dewdrop is the vesicle. The rose is the erythema that you see at the base of the vesicle. Okay, dewdrop on a rose. Now, HSV1 and HSV2, all of the herpes viruses, basically, because they establish then latency, are the gifts that keep on giving. So once you get one of these, you are never getting rid of it, all right? So while we have treatments, the treatments basically control the viral infection, but once you get one of these, you are never, ever getting rid of it, all right? So the gift that keeps on giving. All right, again, rule of thumb, HSV1 infections above the waist, HSV2 infections below the waist. Now we're going to talk first about gingivostomatitis and the cold sores, and really we're talking about HSV1 here. HSV1, as we all know, because it's extremely common, causes cold sores. If you ever want to freak out a family member when they have a cold sore, say, "Oh my gosh, you have herpes." And they will get all kinds of red and embarrassed because clearly they probably aren't aware of that. So the blister-like lesions, usually on the lips and in the oral mucosa. Gingivostomatitis is a lot more severe form of HSV1. And these viruses go latent in the trigeminal ganglia. So what happens the first time you get HSV1? It could be asymptomatic, or it could be fairly severe. You might get gingivostomatitis, which is actually a little bit more common in children when they get HSV1. The virus then goes latent in the trigeminal ganglia. And what happens is you'll start to get the latent virus reactivate at certain points during your life, if you have a cold, for example, which is why we call these cold sores. And as the virus is traveling back down the ganglia, you're going to feel a little tingly sensation that lets you know that he's coming back. And is going to come back usually as that cold sore formation. All right? HSV can also cause keratoconjunctivitis. So if, for example, you're digging in, you get a nice big cold sore blister on your mouth, it's kind of annoying, it hurts, you're picking at it a little bit, and then you go rub your eyes, you can inoculate your eyes with HSV. And with keratoconjunctivitis and HIV, what you're going to see that helps you with the diagnosis are dendritic ulcers. So you're going to do the eye exam, and you're going to see dendritic ulcers that help you with the diagnosis for keratoconjunctivitis. Now, if you look at this other disease, meningoencephalitis, what I really want you to do is think more encephalitis. So what I'm about to tell you now is really important. HSV-1 is the leading cause of viral encephalitis in the United States. That's right. HSV-1 is the leading cause of viral encephalitis in the U.S. All of the arboviruses, West Nile, Eastern equine, Western equine, Venezuelan, California, all of those viruses are there. We do have them in the U.S., but they're not the most common. So what happens with HSV-1 is typically you can get encephalitis when the virus is reactivating and attempting to travel down the nerve. And what happens with encephalitis caused by HSV-1 is you will get temporal lesions. So if they mention temporal lesions on a scan, they're trying to get you to think about herpes viral encephalitis. Now, the other thing to think about is that if this is untreated, it has an extremely high mortality rate. So a 70% mortality rate if this viral encephalitis is untreated. However, now we use acyclovir to treat encephalitis from HSV-1, and that has significantly reduced the mortality rate. So you got a high mortality rate if it's untreated. All right, as far as the genital infections go, now we're talking about HSV-2, one of the leading STDs in the U.S., but probably now HPV is probably a little bit more common. But HPV and HSV-2 are kind of neck and neck, duking it out for top spot. For HSV-2, the initial infection could be asymptomatic, just like we saw with HSV-1. So the first time you're exposed to the virus, you may be asymptomatic, so you may not get that vesicle formation. The virus goes latent. Where does it go latent? In the sacral nerve ganglia. And then it's going to reactivate, travel back down that nerve, and you'll eventually get the presentation that we're all familiar with for HSV, which are the painful vesicles. All right? The vesicles are painful because the nerve is affected. So you're going to have painful vesicles. Now, these vesicles, when they're healing, will eventually kind of ulcerate. So on a differential, clinically what you're going to need to realize is that you may see HSV-2 on a distractor list with syphilis and with chancroid because it will ulcerate and it can look like a chancre. All right, moving on, neonatal herpes. For women who are HSV-2 positive, if during the pregnancy and the birth process we are not aware of that HSV-2 status, the infant can acquire that infection through passage of the birth canal. And when that happens, it's usually not pretty. The infant usually gets an overwhelming herpes viral infection that has a very high mortality rate. So the three types of presentations you can see with neonatal herpes is that we have a disseminated horrific infection with a very high mortality rate. We have kind of more of a meningitis, actually, than encephalitis. Could be encephalitis. So we'll just call that meningoencephalitis. That also has a high mortality rate. Okay? Additionally, the presentation could be vesicles on the skin, and you can have an infection in the eyes or in the mouth. So it may look, in fact, like HSV-1. So those are the different presentation for neonatal herpes. Diagnosis is pretty straightforward. You're going to see those lesions. You're going to know exactly what it is. Most people that have at least HSV-1 can sense when the virus is coming. So if you know when you're going to get another reactivation, a lot of the times they can go ahead and see their physician and get some anti-herpes drugs that can help that infection go away a little faster. So the diagnosis made based on clinical. For encephalitis, we can definitely say it's viral by looking at some of the properties of the CSF, but we can also do PCR on the CSF to specifically detect the herpes viruses. And then for genital infections, one of the things I mentioned to you before is that we can actually look for those giant multinucleated cells. The giant multinucleated cells, remember, are also called syncytia, and there is a specific smear that's called a Zank, but starts with a T, but the T is silent, a Zank smear that will show the giant multinucleated cells. Additionally, you can also use immune fluorescence to detect HSV-1 or HSV-2, and that is kind of slowly replacing the Zank smear because with immunofluorescent staining, you can actually distinguish between the serotypes HSV-1 and HSV-2. They will still ask you about the Zank smear, though, on the boards. Why will they ask you? Because they're trying to give you some specifics for diagnosis. So the fact that you have the giant multinucleated cells, if they say they did a Zank smear and it was positive, you have to know they're telling you that there were giant multinucleated cells there. Now, treatment for HSV-1 and HSV-2, we actually do have some specific antiviral drugs for the herpes viruses. And kind of the first generation of these is acyclovir. Acyclovir is a really good drug, and so are the additional drugs, the second generation or the second line of anti-herpes drugs. But they're really good because of this reason. They are specific and will only become activated in cells that have a herpes viral infection. And the reason that is because they target specifically the viral thymidine kinase. All right? Now, what thymidine kinase does is it helps the virus replicate. All right? And what happens is acyclovir, famciclovir, valciclovir require being turned on into an active drug by the thymidine kinase. So you don't see a whole lot of really bad side effects with the herpes viral drugs because they only get turned on in cells that have an active herpes viral infection. All right? You've all seen the commercials for these. Again, they make it sound very romantic to have herpes. They're always walking on the beach, and they're talking about how, they use valciclovir to suppress their outbreaks. So if you put all this information together, let's see, we have romantic walks on the beach. The vesicles look like a dewdrop on a rose. It's kind of romantic. And it's a gift that keeps on giving. So you got to be careful about those herpes viruses. All right. We're going to move on to VZV, or varicella zoster virus. The reservoir for VZV is basically the mucosa, and of course, because of latency, the nerves. Now, I want to spend a little bit of time on transmission, okay? Transmission is predominantly through the respiratory route, all right? Through the respiratory route. Now, I know some of you are sitting there thinking, well, if somebody has a vesicle and I touch it, can I get VZV? Well, yeah, you can. But predominantly, how do you think it's going to spread? Do you think it's going to spread through respiratory means before you actually have that hideous rash? Or do you think it's going to spread predominantly by people going and touching the hideous rash? Yeah, probably respiratory. So we're going to go with respiratory for VZV, knowing that you can get it from direct contact, but that is much less likely. Now, as far as the virulence, you're going to inhale the virus through the respiratory tract. You'll get some replication in the local lymph nodes, and eventually, once the virus gets into the blood, we get a viremia. Once it gets into the blood, it will infect some target organs. It will eventually go latent then in the dorsal root ganglia. It is only after you get the secondary viremia from the additional release of the virus from the spleen and liver that you start to see the presentation of the rash. Okay, here is a really good example. I'm going to point something out. If you look at one of these vesicles, you can see the dewdrop on a rose. You see the vesicle, and you see the erythema at the base of the vesicle. So that's what that term is trying to describe. Now, with chickenpox, one of the things I'm going to point out for you is that it is, number one, an asynchronous rash, and you will see vesicles with chickenpox in all different stages of development. So we are going to have macules, we are going to have vesicles, and we are going to have scabs all on the same patient. And that wasn't all that important because when people got chickenpox, it's very obvious. It's like, wow, you got chickenpox. But now with the biological warfare questions making their way onto the boards, you are going to have to be able to differentiate VZV from smallpox. And I'll talk about this now, and then I'll talk about it again as we get into smallpox. With smallpox, the difference is all of the vesicles are in exactly the same stage of development. So if somebody has smallpox and they have vesicles, they are all vesicles. If they have scabs, they are all scabs. Whereas in VZV, the vesicles kind of come in crops. So you'll have the little macules, then the vesicles, then the scabs, all on the same patient. Additionally, you're really not going to feel very well. You're going to have fever, malaise, sore throat, classic what we would refer to as flu-like illness, and then you're going to have the rash. The virus goes latent in the dorsal root ganglia, remember, and when it reactivates as shingles. Shingles is really easy to pick up because it only affects one dermatome, which means when you see shingles, as you can in this bottom image, it only affects 1/2 of the patient. So it's unilateral. So here, where it's really on the patient's chest, it's only on one side. If it affected the face, it would only be on one side. Again, when the virus is traveling back down the nerve, you're going to have a lot of pain associated with shingles. Most of the people that have had shingles before have a lot of pain associated with it, okay? Then you'll get the outbreak of the vesicles. One of the things I need to mention here that's sometimes confusing, somebody will always say, well, I know somebody has shingles and never had chickenpox, and they'll swear. But the only way you can get shingles is if you had a primary infection with VZV, which means in order to get shingles, the virus has to have been latent. So you had to have had it around before. You could have had a clinically inapparent case of chickenpox. That happens all the time. But the virus is still in you. Remember, you can't get rid of it. And then it's going to travel back down the dorsal root ganglia to cause shingles. Now, if somebody has shingles and they are around somebody that has never, ever had chickenpox or been vaccinated, that person is going to get chickenpox, not shingles. So it's important to know the difference. For diagnosis for varicella zoster virus, a lot of the times that's made on clinical diagnosis, very, very straightforward. You can do a confirmatory test, and you'll notice here that the zinc smear is also pertinent for VZV. Keep in mind that, again, these are all herpes viruses. VZV has a fusion protein, so again, you can see the formation of those giant multinucleated cells, which are identified by the zinc smear. One thing I will mention, you can see in VZV, you can see pneumonia as well as a complication. And one of the things they'll describe is it's sometimes called giant cell pneumonia. Now you'll see something very similar in measles because, again, the paramyxoviruses also have a fusion protein in the envelope. Viral isolation and cell culture you're really probably not going to need to do for VZV. Treatment for varicella zoster virus, typically you're probably most of the time it's going to be untreated supportive care. You can give acyclovir in a lot of the drug or a lot of the infections that are not HSV1 and 2, but the viruses are not as reliant on the thymidine kinase, so they have kind of a limited effectiveness in all the viruses outside of HSV1 and HSV2. You can give acyclovir, though. For immune-compromised patients, you would give IV acyclovir, and especially in the case of something like VZV encephalitis, which can happen very easily in someone that's immune-compromised. One of the contraindications for VZV is giving aspirin. Giving aspirin with VZV can also cause an encephalitis known as Reye's syndrome. Prevention of VZV, we now have a live attenuated vaccine, and this vaccine is on the recommended list of vaccines for all children in the U.S. And so as of now, on the board exam, if you get a question on VZV, there has to be, in order for really it to be chickenpox, if it's not really obvious, you are going to have to see somewhere in that history that it is an unvaccinated child, okay? Now, the other thing that we can do is we can give varicella zoster immune globulin for a post-exposure prophylaxis for immune-compromised patients, again, because they are the ones who will tend to get the complications from VZV, including pneumonia and encephalitis. Okay, we're now going to move on to EBV, Epstein-Barr virus. The reservoir for EBV is humans, and it's very easily transmitted, and currently over 90% of the adult population is likely seropositive for EBV. What happens is most of us are exposed to EBV while we're children, and if we're exposed to EBV as a child, the disease itself that you get with EBV, which the primary disease is mononucleosis, is really a civil war between your B and T cells, where your B cells get infected with a virus, and now the T cells are trying to kill the B cells that are virally infected. Now, in a child whose immune system is not yet fully developed, they're much more likely to be asymptomatic with EBV. So they get EBV. By the time they're adults, they're still seropositive for EBV, but they may have never had a clinically apparent infection with Epstein-Barr. Now, pathogenesis, we mentioned this when we were talking about viral receptors. The virus itself affects not only the epithelial cells in the nasopharynx, but also B cells. And remember specifically CD21. EBV goes latent in B cells, okay? So you definitely have to remember the sites of latency. EBV goes latent in B cells and again uses the receptor CD21. And as is shown here, you're basically looking at a constant battle because now what happens is EBV causes nonspecific proliferation of B cells. Now your cytotoxic T cells are having to control the infection in the B cells. So you will get, what do you know about mononucleosis? Whoosh, massive lymphadenopathy, splenomegaly. Why do you get that? You get that because your B cells and T cells are duking it out in this particular disease. Now, one of the things that you may see, very likely, if you do a blood smear of somebody with EBV, you have a tendency to see as high as 70% of that white cell count can be reactive T cells that are also called Downey cells. And I will show you a picture because, again, that's an image that could likely show up as far as a diagnosis type question. Now, again, EBV is infecting the B cells and causing them to nonspecifically proliferate. The key is nonspecific. So we're not getting a B cell response to EBV. We are getting a B cell response that is heterogeneous because the virus itself acts as a mitogen. which is going to nonspecifically proliferate those B cells. Because of that, though, we get the formation of the key diagnostic tool for EBV, which are the heterophile antibodies. The heterophile antibodies are produced because EBV causes the nonspecific proliferation of B cells. The disease that we're going to first talk about, of course, is the kissing disease or mononucleosis. On a vignette on the boards, you are going to see this as usually a high school age child that comes in presenting of maybe pharyngitis and major fatigue and lymphadenopathy. And the first thing that should pop into your mind is mononucleosis, all right? So you have fatigue, lymphadenopathy, and fever, also sore throat, and splenomegaly. So one of the things you have to be careful about with EBV are children that are EBV positive playing contact sports. If you have splenomegaly and your spleen is all enlarged and you get tackled on a football field, there is a really good chance that your spleen could rupture. And then, of course, with that being a very large blood supply, you're going to risk losing a lot of blood really, really quickly. So contact sports we're not going to do with EBV. And again, you want to know that EBV goes latent in the B cell. Several other diseases are associated with EBV. One is a lymphoproliferative disease in which people that have a T cell immune deficiency, the B cells, remember, are getting infected with the virus. The T cells usually are trying to control that infection, which gives you the lymphadenopathy and the splenomegaly. In this case, the T cells, there's a deficiency and they can't control the growth of the B cells. So a lot of the times you'll see this in immune-compromised patients, and it's going to look like a B-cell lymphoma. Now, hairy oral leukoplakia is something that happens quite frequently in AIDS patients as more of an opportunistic type infection. And what happens is the tongues of these patients start projecting these little hyperproliferations, and so it almost looks like there's hair projecting from the tongue. And that is also caused by EBV as it's functioning in more of an opportunistic infection. Now, Epstein-Barr is one of the main viruses that is associated with a lot of different types of cancers. So we're going to look at some of those. Burkitt's lymphoma, for example, is a cancer. It's a B-cell lymphoma. Typically you'll see it in the jaw. And you'll find it very frequently in areas of Africa where malaria is likely a cofactor. So it causes kind of this lymphoma of the jaw, where the jaw gets all distended in the kids. Sometimes the inflammation is so pronounced with the lymphoma, you know, they'll actually start to block the formation of their eye. Their eyelid won't be able to open. And once those children are actually treated, though, that will usually resolve upon treatment. Now, AIDS patients can also get Burkitt's lymphoma, but they'll tend to get it abdominally, and it's more than of something that we would see in immune-compromised patients. Another type of cancer that is found in higher incidence in Asia is nasopharyngeal carcinoma, and pretty much worldwide from EBV infection is actually Hodgkin's lymphoma, all right? So different types of malignancies that are associated with EBV, probably with Burkitt's lymphoma and then Hodgkin's lymphoma being probably the two that you should really remember that have a higher clinical relevance probably than nasopharyngeal carcinoma. Now, diagnosis for EBV is something that you might be asked to do. And there are two major things we have to think about here. Number one is if you have a patient presenting, again, typically in their teens, with fatigue, sore throat, and lymphadenopathy, maybe splenomegaly, they're going to do a heterophile antibody test. And if they are heterophile antibody positive, that is going to confirm for you the diagnosis of EBV. Now, another thing that we mentioned is that if you do a blood smear from somebody with mononucleosis, what you'll see very commonly in the blood, if you look down in this image, are atypical T cells or Downey cells. So here's one here. There's another one here. And those cells are often described as atypical reactive T cells. What are they reacting to? If you're looking in that image, you can see they're actually reacting to the blood cells. So they react and bind to the blood cells, and they can make up, remember, about 70% of the blood smear in somebody with mononucleosis. Now here's a question for you. What other cell type do you think would be increased in the blood of a patient with mononucleosis? There's a big clue there. Monocytes. Mononucleosis, monocytes. So you have the atypical reactive T cells, and you have the monocytes that are also going to be elevated in the blood of somebody with mononucleosis. Now, this is just a general cartoon and depiction of EBV, showing you again that it's an icosahedral virus, okay? And it's also envelope, so you're looking at some of the envelope proteins. But there are other antigens and viral markers that we can look at with EBV that are present in the virus that tell us certain things about the infection. For example, the EBNA protein. One of the things that's really important about EBV is the Epstein-Barr nuclear antigen. The EBNA protein is always associated with transformed cells, okay? So just kind of keep that in mind. Now, for treatment of EBV, usually it's symptomatic care. For someone that's immune compromised, where we really worry about lymphoproliferative disease, we're going to attempt to use acyclovir or one of the other herpes drugs. Now, we're going to switch gears just a little bit and talk about CMV, fitting right in with EBV, because CMV is a major cause of what we call heterophile negative mononucleosis. All right? CMV is cytomegalovirus, and again, like adenovirus, you can see lots of different means of transmission. We've got saliva, sexually transmitted, parenteral, in utero, crossing the placenta. Okay? So CMV infects the salivary gland epithelial cells. Again, you can get a mononucleosis-like disease, but it's not generally limited to that. And we're going to talk about all the different types of diseases you can see with CMV. Now, the site of latency for cytomegalovirus are mononuclear cells. All right, so you have B cells for EBV and mononuclear cells for CMV. Now, what I want to show you about CMV that's going to really be helpful in the diagnosis is something called an owl's eye inclusion. So you're going to look at this cell, and you can see that it resembles an owl's eye. If they say owl's eye inclusion, or if they show you an image that looks similar to the one that we're showing in this picture, that is diagnostic for CMV. Okay? So we have heterophile negative, but boy, if they tell you about the owl's eye inclusions, you're going to have to go with CMV. Okay, we're going to talk about the different diseases, and probably most important is the fact that in the U.S., CMV is the most common in utero infection. Okay, so again, you get some random symptoms in a newborn or a fetus maybe that was born a little bit early, and you can't specifically pick out which agent it was that crossed the placenta, and they simply ask you what's most common, you're going to answer CMV because it's the most common in the U.S. Now, some of the things that might help you figure out that it's CMV, okay, is the fact that we have this thrombocytic purpura. And what you'll sometimes see with CMV is this presentation that was sometimes called a blueberry muffin baby, because they'll have these purplish, bluish splotches or rash on the fetus. So blueberry muffin baby, that is really kind of a buzzword for you for CMV when it crosses the placenta. It also causes CNS damage. There is a lot of mental retardation associated with in utero infections with CMV as well. but it's the most common, and we do not vaccinate for CMV. All right, what other diseases? Mononucleosis. Children who are exposed or adults that are exposed to CMV would get a heterophile negative mononucleosis, okay? So you're reading those symptoms, again, fatigue, pharyngitis, lymphadenopathy, and they say that it's heterophile negative, then CMV is probably going to be top on your list, okay? Now, a couple of other diseases we want to talk about for CMV. Number one is in transplant patients and also AIDS patients, one of the most common things to see is pneumonia. So you'll see interstitial pneumonia from CMV in almost 100% of transplant patients because of the severe immunosuppression. You can see this in AIDS patients as well, and additionally in AIDS patients you can also get CMV retinitis. So in addition to being the most common in utero infection and probably second on the list for mono, first on the list for heterophile negative mono, it is also a really clinically relevant opportunistic infection. All right, diagnosis. How are we going to do it? We're going to look for that owl's eye inclusion that I showed you earlier. How are we going to treat it? In a healthy person, it's simply just supportive care, okay? In an immune-compromised patient, we're going to have to use some of those herpes drugs that we talked about earlier. Now, in immune-compromised patients, we would typically use either ganciclovir with foscarnet, with or without, and you have to make the call, human immune globulin, to passively immunize that patient as well. The best mechanism we have of prevention for CMV are safe sex, because it can be transmitted sexually, and also screening of blood and organ donors. Now, I'll give you one little cautionary statement here. As far as CMV goes, because there's a good bit of the population that is infected with CMV, it's very hard to not give someone an organ because it's CMV positive. But they will try, if they can, to screen that and not to do it, especially if the recipient of that transplant is CMV negative. Now, the next two viruses we're going to talk about are human herpes viruses. We have HHV6 and HHV8. Human herpes virus 6 is actually the causative agent of roseola. And we mentioned it when we were talking about the 5 classic childhood xanthoms, okay? But this is a very clinically relevant and significant disease that is very common during childhood, for which we have no vaccine, all right? So HHV6 is a respiratory virus, and what happens is it replicates in mononuclear cells, and the disease you can easily mistake for other things if you're not listening. So turn up the volume, here we go. Pay attention. It's listed here, fever for 3 to 5 days followed by a lacy body rash. But that's not the entire story. With roseola, you get an extremely high fever for 3 to 5 days. We're talking so high we can get febrile seizures, okay? Then here's the clicker. The fever goes away, and then we get the appearance of the rash, okay? So in this particular case, you're reading a vignette, and you're like, fever, and then they had a rash, but now that they have the rash, they have no fever. That is specific for roseola. But if you don't pay attention to those clues and the fact that they're afebrile at the time that the rash appears, you're going to miss it and misdiagnose it and get that one wrong. So you have to really pay attention to that one. Diagnosis and treatment, we're talking really made on clinical grounds because that's so characteristic. The first week my daughter was in daycare, she got roseola. And as soon as we took her into the pediatrician, it was just like bam. Knew exactly what it was because she had this lacy body rash, but she was afebrile. But right prior to that, she had a very high fever for a few days before that. And we really have no specific treatments for HHV6, although because of the seizures, a lot of infants have to be hospitalized. All right, the last of the herpes viruses we're going to talk about is human herpes virus 8. And what you need to know about HHV8 is it is the causative agent of Kaposi sarcoma. Okay? We initially thought it was maybe a cofactor, but now we know that it is the causative agent of Kaposi sarcoma, transmitted typically sexually or by close personal contact and saliva. HHV8, remember, is something that you're going to have to differentiate from bacillary angiomatosis, which you're also going to see in AIDS patients. Now, if you read the pathogenesis for HHV8, you'll see that the virus itself turns on vascular endothelial growth factor, and that starts causing the hyperproliferation, again, of the vasculature, so you'll start to get those purplish splotches. Again, bacillary angiomatosis is very, very similar. Okay? As far as diagnosis, usually that's made clinically because the rash is so obvious and there is no specific treatment for HHV8. Also, as of right now, we don't know the site of latency for HHV8. Okay? So you won't be required to know that. Okay, the next couple of tables I'm going to show you are, again, what we like to call the money table. This is invaluable for comparing the herpes viral infections. It tells you what the site of the primary infection is, what the clinical presentation of the primary infection is, where the site of latency is, if we know it, and what it looks like when it recurs. Okay? So you can clearly look at HSV1 and HSV2. You can see the different disease presentations, the sites of latency for all. So this is a really good table that is continued here on the next slide, again, with that same basic information. So you definitely want to flag this, turn your page down, whatever you need to do, but this is a really good table for summarizing all of the information that we just went through for the herpes viruses.